Hello, I'm Eric Topol, editor-in-chief of Medscape, and I'm really privileged today to be joined by Dr. Ashish Jha, who is the White House lead for the coronavirus response and who has weathered a tough pandemic time since he joined the administration. So Ashish, really welcome. Great to have a chance to be with you.
Eric, thanks for having me here. I'm really excited to spend some time with you.
You know, sometime several weeks ago, I'm actually trying to remember when it was, you had called attention to the Paxlovid issue, whereby a lot of people of advanced age, let's say 65 and older, were not among the people who were most frequently getting Paxlovid. So you called it out, and I wonder if you could just review where we stand on that.
Yeah. So as you know, Eric, and you've written about this and talked about this, Paxlovid is extraordinarily effective at keeping people out of the hospital, preventing death, preventing serious illness. And we also know, of course, with this virus, with SARS-CoV-2, that it's older people who are at highest risk. And particularly right now, while that's always been true in the pandemic, right now, when we look at the 400 to 500 people dying every day, almost all of them are people over 75. And yet what is interesting to me, and interesting in not a great way, is that when you look at Paxlovid use, it certainly goes up with age. But then once you get to about 75 or so, it actually starts declining very rapidly. And there's just a lot of people who are dying today who are not getting Paxlovid, and it is a really major problem. And I think the issue, I mean, we can talk about what the issue might be, but people in their 70s and 80s should not be denied treatments, and too many of them are not getting treated when they get infected with SARS-CoV-2.
Right. So as you underscored, the studies, not just the randomized trial, but also subsequent effectiveness studies have shown, in fact, many better than the randomized trial, a 90% reduction of hospitalizations and deaths in high-risk groups. Now, Medscape went ahead, after you pointed this out, to do a survey to try to find out from clinicians, including physicians, pharmacists, nurses, why aren't the people of advanced age getting Paxlovid? And they had over 1,500 respondents. And number one on the list was fear of drug interactions. There's a lot of data to suggest that most of the drugs, the vast majority, there's not an interaction of worry because you can just stop the drug, let's say a statin, for 5 days.
Yep.
What do you think about that reason? Obviously, there are more people in advanced age that are taking drugs, other medications, but do you think that that's a reason to withhold Paxlovid?
Yeah, it's a really interesting question. You know, when Paxlovid first came out about a year ago, I think there was a lot of confusion about how serious are these drug-drug interactions. You know, as you know, Eric, over the last year, we've had a whole bunch of clinical societies, really the organizations like the Infectious Disease Society of America and others put out guidance for physicians on how to think about drug-drug interactions. The truth is that almost every medicine can be given, or almost everybody can get Paxlovid, no matter what medicines they're on. There are two that IDSA basically says if you're on it, it's really a problem. You know, rivaroxaban, obviously, and then salmeterol. These are two drugs that are used, but other than that, every other drug, if a patient's on it, still give them Paxlovid. You just have to sometimes make modifications. You may have to lower a dose. You may have to stop something. I always remind people, we do that kind of stuff all the time clinically. Somebody's going in for a dental procedure. We often stop their blood thinner. Somebody's gotten dehydrated from a situation. We often will, stop their blood pressure medicine for a short period of time. These are not unusual things for clinicians to manage. So it's another way of saying there really is no good reason, I believe, that people can't get treated. And then for the people who are on those two medicines, there are other options, right? There's Lagevrio. There is obviously a little bit more difficult to do, but IV remdesivir, which is given as an infusion. So you still have other options. In my mind, there's no good reason not to treat somebody who's older and higher risk. And most of the times you can use Paxlovid.
Right. Now, the second area that was interesting to note is the concerns about rebound. That is, physicians were saying that I wouldn't want to give Paxlovid because then they'll rebound. And obviously, we have had some high profile people that experience rebound
Yeah.
that you're very familiar with. However, when we did a systematic study with Michael Mina and the group at Scripps of hundreds of people, where we tested their PCR testing and rapid testing, and we did it systematically over the course of more than a couple of weeks, we only saw a rebound compared to people who didn't take Paxlovid in about 10% of people, whether that's defined by positive tests or by symptoms, that is the excess. So although some people have believed in the Twitterverse and other places that the Paxlovid rebound is really common, when you look at it carefully, there's even rebound, of course, when people are not treated with Paxlovid and the rates aren't that high. So what do you think about this rebound reason for not giving treatment?
Unfortunately, it has become a bit of lore. And again, it didn't help when very high profile folks like Dr. Fauci and the president of the United States got rebound. But I always say, look, anecdote aside, you got to go to the evidence. And you guys in the study, you pointed out some of the best evidence we have in a contemporary population. And the things I will point out, Eric, and you mentioned this, but I want to reemphasize for clinicians, is, for instance, you saw in people who did not get Paxlovid, about 9% of people got rebound. In people who did get Paxlovid, that number was higher at 14%, but it was a very small difference. Not statistically significant, by the way. There was no statistical difference between those two groups. So it's not even clear that you're getting more rebound with Paxlovid than with no treatment at all. But I always remind people that when people do get rebound, which is infrequent, it doesn't lead to people getting super sick and getting up in the hospital. So you have to ask yourself, why are you giving Paxlovid? If your number one goal is you got somebody who's elevated risk, you want to make sure they don't end up getting sick, you want to make sure they don't end up in the hospital, you tolerate a tiny bit more rebound for this massive benefit of preventing serious illness. It is the biggest clinical no-brainer. So I think this has gotten kind of a little bit overemphasized. Again, I do think social media is not helpful. Every time somebody has rebound, they report it. The millions of people who have not had rebound are not on Twitter saying, I didn't get rebound. And that is a classic bias in information ascertainment. And as clinicians, we got to look beyond that and go to the evidence.
Right. No, I certainly thought that when we did the study, it was going to be at least 30 to 40% based on the bias of reporting, as you really highlighted. The other thing that's interesting about Paxlovid, which we didn't expect, is that because of the inactivation of the virus, basically stopping replication soon after it's taken, is there might be a reduction of long COVID. And the study from the Veterans Affairs group certainly suggested that you could reduce by at least 25, 26%. That seems like a bonus factor that doesn't get adequate regard. I don't know if you buy into that possibility.
Look, it's an observational study, so obviously we're always going to be thoughtful about not over interpreting it, but it's an observational study in the context of logic and reason about what causes long COVID. Now, we think there are multiple factors that contribute to long COVID. But it stands to reason that if you shut down viral replication, you have less viral replication happening. It stands to reason you're going to get a different kind of immune response. You may get less immune dysfunction. One of the things that we think may be causing some amount of long COVID is persistence of virus. Well, if you shut down viral replication with a really powerful antiviral, you're going to get less persistence of virus. So there are a lot of mechanisms by which it makes sense to me that Paxlovid would reduce long COVID. Again, we're going to get more data on this. But yet one more reason to use it. I remind people that at the end of the day, when you have a powerful antiviral like Paxlovid, you really got to begin with the question, why am I not giving it to the person? As opposed to why should I give it to the person? Given all of the benefits that we are seeing, it seems to me very clear. I'm 52. I'm thankfully relatively healthy. I would take it. I'm eligible. And I have certainly encouraged my family and friends to do it. And I've been saying to my clinician friends, you have to begin everybody who's over 50 or has chronic conditions, you have to ask yourself, why am I not treating this person? And if there's a very good reason to not treat them, fine. But other than that, your default should be, I think the standard of care is you treat people with infections, you got a viral infection, you've got a very good antiviral, you should treat that person.
Yeah, that gets to another issue, which is, when you took over to lead the coronavirus response, you had limited tools. That is, you weren't getting a new billions of dollars of support from the government. So you did something with your colleagues that was actually pretty much unprecedented. That is, you gave pharmacists the power to prescribe, so this wouldn't have to be a hang-up of getting a hold of a physician. And what was surprising in the Medscape survey is that pharmacists were reluctant to prescribe Paxlovid. Comments about that?
Yeah, and this was a decision made by the FDA, and I think my feeling has been, well, first of all, I'll take a step back and say I think pharmacists are among the most underutilized healthcare providers in our healthcare system. I mean, they have a lot of capability, and certainly when you think about a drug like Paxlovid, where the main concern may be around drug-drug interactions, well, guess who understands drug-drug interactions really well, right? It's pharmacists. That said, I think sometimes some of the pharmacists, again, because they're not maybe used to prescribing often to complicated patients, there may be some of that learning curve that's still going on. I was also surprised to seeing that Medscape survey, the low rates of prescribing among pharmacists. My hope is over time, with more comfort, with more experience, with that getting out there more, we're going to see more and more pharmacists prescribing. It's a really important access point for a lot of Americans, particularly a lot of poorer Americans who don't often have a regular source of care, but they go to the pharmacist twice a week. They go there at least a couple of times a month to pick up medicines. They know their pharmacist, the pharmacist knows them. It's an important access point that we got to try to figure out how to help bolster and support.
Right. Now, the other issue, of course, is that as the pandemic's gone along, we've lost the ability to use monoclonal antibodies that were initially quite potent, and we had different choices. And then eventually, as we've gotten into these more recent variants, they've basically outrun our ability to have antibodies that are effective. So we're left with a pill rather than a infusion of an antibody or Evusheld that really was a preventive tactic for people who are immunocompromised. So that's left us with this drug that, but eventually it's possible, I guess, that we could see resistance. There have been some actual strains of the virus where the MPRO, the main enzyme responsible for replication, has mutations in it where we could potentially see. But what are your thoughts here, where we don't have a whole lot of backups for people who have high risk, like the people of advanced age, and there's little else that we have to offer?
Yeah, this is actually one of the real unfortunate side effects of congressional inaction and lack of funding. Look, as the pandemic has gone along, what you want to do is you want to see an expanding toolbox, more and more therapeutics, more and more treatment options, we've actually seen a shrinking toolbox. And the reason is, if you think about it, 2 years ago, we had monoclonals, and when one monoclonal stopped working, we had two more in our toolbox, and one of them could get pulled out. The reason that existed is because we had funding, and so we could go and work with companies and say, if you build it, we'll buy it. And that created the incentive for companies to build it. And we had a nice number of monoclonals. And if we lost one or two, we could manage. Once the funding ran out, the company stopped investing in new monoclonals. And so we've had no new monoclonals come onto the market or made by a company in almost the last year. And so now when we lose it, we got nothing to replace it with. We're finding ourselves in a worse place in terms of therapeutic options. Look, I think it's fantastic that Paxlovid is working as well as it is. We do have Lagevrio, which, again, the clinical data suggests is not as good, but has some benefit. And then obviously you have remdesivir. But the truth is, the mainstay now is Paxlovid. And we don't want to be so reliant on one medicine, especially when, as you said, there's been in the laboratory, the emergence of resistance, and you worry a lot about what happens if that becomes clinically widespread. We will find ourselves in real trouble. So we're trying to figure out what we can do in the administration to try to encourage more development of more therapeutic options. But Eric, this is not where we should be as we start our fourth year of this virus. We should have more and more tools in our toolbox, not fewer over time.
Right. Now that gets us to what you have touched on, which is the lack of support, the recognition that we're not done with this virus
Nope.
and that we need other treatments, ways to prevent. And you've been a champion. I want to recognize that you have tried everything you can, as far as I know, to get backing for nasal vaccines, things that would achieve mucosal immunity, whether it's oral vaccines, next generation vaccines that would be
Yep.
more durable, variant proof, that would have less side effects. But you've hit obstacles. That
Yep.
is the lack of support. What is the basis for this lack of support, you think?
Well, in some ways, it is a little bit of the sort of victim of one's own success. Like the truth is, the vaccines we have right now, the mRNA vaccines, are extraordinary. They are extraordinarily good at preventing serious illness and death. And because of the high levels of vaccinations, and obviously, and some from the infections, we have had a period of time, a 10-month period, where death numbers have been relatively low, still too high, but relative to the earlier part of the pandemic, way, much lower. And I think it changes the discourse on making the case for this. It becomes harder because people are like, well, our hospitals are no longer overwhelmed. Well, we're not seeing 2,000, 3,000 people dying every day. Well, thank goodness. We don't want to be seeing that. But the numbers we're at now, 400 to 500, still too high. I think we can dramatically lower that. I think we can do much better, but we're going to need more tools in our toolbox. And so we have made that case, or tried to make that case pretty aggressively to Congress. But I will tell you, Eric, that we're not done. Like, we're going to look in every place we can within the federal government, go back to Congress as we need to. We got to keep fighting this fight, because a lot of people are dying unnecessarily of this virus. The virus is going to be with us for a very long time, probably for the rest of our lives. And we need a long-term strategy for managing it that doesn't lead to 150, 200,000 Americans dying every year. I just think that is an unacceptable toll. And we have the ability to do something about it. And certainly in the administration, we're not giving up.
Yeah, and what's sad here is that the science is pretty extraordinary. So, for example, you mentioned about the monoclonals. There's so many potent variant-proof monoclonals that have been identified, most of them naturally occurring in certain treasure chest people that have developed these potent antibodies, and they're not being pursued because of the funding not being available. And then it extends to, we're seeing nasal vaccines being developed in India that is using licensed intellectual property from Washington University. We're seeing it developed in Mexico, licensed from Mount Sinai in New York, and obviously China and other countries for nasal vaccines. Do you think some of this, where the science is solid, but the unwillingness to take on risk and put the funding, is this fall into the complacency umbrella, or is it just that they don't believe these reports, or what's going on here?
I think it's complex. I do think, first of all, you're absolutely right. The science here is beautiful and has been moving in the right direction. A lot of that science being done here in the United States. I remind our friends up on Capitol Hill that while these are nasal vaccines and mucosal vaccines are good for COVID, they're also going to be good. That technology and building it and learning about it is going to help us with the next coronavirus outbreak. Because look, the truth is, we've had 3 deadly coronaviruses that have popped up in the last 15 years. And anyone who thinks that we're done with coronaviruses is kidding themselves. We may very well get a pandemic flu at some point. Knowing how to build intranasal vaccines can be incredibly powerful for any respiratory pathogen. So there are some very important long-term investments here. I don't think it's kind of anti-science. I just think people, as I said, they sort of feel like, well, if it's just investments for COVID, we've made so many investments, we're in so much of a better place. And we have been making the case, I think, more recently, that this goes well beyond just COVID, that this is really important for the long-term security of our nation. And I'm finding more and more people both beginning to understand that and really starting to get motivated by that.
One of the things that strikes me is that people tend to think about flu and how that's the same for SARS-CoV-2. That is, the nasal vaccine FluMist is just not that potent. It's only useful in certain patient populations. Tamiflu is not a very strong pill. The vaccines don't work that well. And here you have a virus where we've had vaccines that were before Omicron set in, 95% effective against every outcome, and including infections and transmission. We have Paxlovid that makes Tamiflu look like a weak hitter. And we have a whole different virus that is eminently potentially more susceptible to a nasal vaccine. And we've seen, some success. So do you think this idea that flu as a precursor is part of the reason why people have a defeatist attitude about coming up with better treatments such as nasal vaccines?
It's a really interesting question, Eric. I hadn't thought of it that way, but I think you're absolutely right. First of all, flu becomes our kind of default comparison, right? People have done this from the beginning. Oh, it's just like the flu, or it's not like the flu. I always remind people, or even now when people say, oh, it's not any worse than getting the flu. I'm like, if you've ever had the flu, it's pretty miserable. It's pretty miserable.
Yeah.
In a bad flu season, it kills 30, 40,000 Americans. Like, it is a bad virus. So I don't know that that's something we should be trying to achieve, like, oh, it's only like the flu. But the other part that you're absolutely right on is our tools against the flu have never been terrific. They're just not that great, right? And our vaccines, some years are good, some years are a miss. The Tamiflu is very weak. It doesn't have a large impact on hospitalizations and deaths and the outcomes that we really care about. And with COVID, we have the ability with these investments to make COVID something that becomes far more manageable. We can really tame this virus, but we're going to have to make those investments. And I always sort of remind people, like, let's not use flu as some golden ideal. We should be able to do much better than that.
Right. Now, lastly, about boosters, we have now the FDA meeting this week to basically come up with a plan that was used this past year of picking a bivalent in June, rolling it out in September. That has had a mixed response, but particularly poor uptake among Americans. Even those who are at high risk that we would say benefit particularly from Paxlovid, less than 40% have had a booster. So how are we going to just keep along with this booster plan when there's progressively less interest in getting these shots? There's obviously the reactogenicity and side effects that people don't want to sign up for. So the support for boosters that don't block infections. I mean, it seems to me that people are talking and they say, we want something that blocks infections like they used to. Are we listening? That is, do we have the capacity to listen to what people want so they could get charged up again? Or are we going to just or basically going to have a problem of getting reception for more booster campaigns?
Yeah. There are several really important questions embedded in that. So let me take them all on. First is, there is no question people want a vaccine that prevents infection and blocks transmission. And that's where we got to invest in mucosal vaccines, right? Because that's our best bet here. And I think this is one of the reasons we've made this a priority in the administration, and that we've gone to Congress multiple times. And again, we're actually doing a lot with the resources we have, and our hope is to do more. So no question, I think the American people want it. It's clearly scientifically important for public health. We got to do that. In terms of the booster campaign, it's been a long 3 years. People have gotten a lot of shots. What I sort of remind people is, people often say to me, well, is this my 5th shot or 6th shot? And how many shots do I need? And I always say, I think I've probably gotten 28 shots of the flu vaccine, because sometime in my early 20s, I started getting them, and I get it every year. And I don't go in the fall and say, I think this is my 29th shot of the flu. It's just my annual flu shot. I get it because it prevents me from getting sick, seriously sick over the flu season. I think that moving towards something like that, where it just becomes a routine, it becomes part of how you keep yourself healthy, that for a majority of Americans, and we'll see what FDA comes out with, but for a majority of Americans, you get it once a year. And so if you're a 35-year-old, a relatively healthy person, you get your COVID shot in the fall, and you've got waning and you may not have as much protection against infection in the spring, but you're relatively healthy and you're going to do fine. Maybe for higher risk people, it's a bit of a greater cadence. We'll have to see. But the bottom line is we've got to routinize it, and then we've got to build the vaccine tools that allow us to kind of get out of the cycle that we're in right now. But in the short to medium run, my gosh, if we can get people vaccinated once a year, maybe high risk people a bit more often than that, it will drive deaths way, way, way down. And that's what we got to stay focused on.
Well, we'll be cheering for you and hope that there'll be a break in this relative impasse. We need it, as you said, and I think we all acknowledge that this virus is here for many years ahead, and we don't know whether there'll be a new family like an Omicron that we've had for over a year, which is even more formidable as a challenge. And that's why being prepared would be a whole lot better than where we stand now. So thanks so much for joining me. I really enjoyed this conversation. I think it's been illuminating about better uses of Paxlovid that override some of the concerns seen in the Medscape survey. And hopefully over time, we'll have better armamentarium to deal with this virus and someday even get ahead of it compared to always chasing its tail. Thanks so much.
Hey, Eric, thank you for having me. It was really a pleasure.